Hello and welcome to this presentation on perinatal palliative care. My name is Thomas Bouchard and I'm a family doctor in Calgary, Alberta, Canada. And this presentation is for the Operation Thrive program. So the first thing I'd like to say is that I don't have any financial ties or disclosures to make. The views aren't representative of my organization. And I just want to thank the families who have participated in my own perinatal palliative care program and have shared their stories and their pictures for this presentation. So the first thing I'd like to say is just talk a little bit about the origins of perinatal palliative care. Then I'll give you a few case studies. And then we'll consider some models of care that you guys as medical students and residents could consider as you're going into your careers. We'll look at some resources and research and then suggest how you might get involved. So the first thing I'll say is that the term perinatal hospice was coined by an American, Dr. Byron Calhoun, from Charleston, West Virginia. There's a great paper from 2001 that he co-authored called Perinatal Hospice, which is kind of another term for perinatal palliative care. And the explanation he gives for what this model of care is a model that incorporates the strengths of prenatal diagnosis, which would be an MFM OBGYN doctor, perinatal grief management, which can involve social work or a family doctor, and then hospice care, so the best that palliative care can offer for the families and their babies. There's a more recent article that Dr. Calhoun wrote called The Myth That Abortion is Safer Than Childbirth. So it's an opportunity to kind of think about a common misconception that, the birth itself will be too difficult for the mom and the baby, so you should just choose an abortion. So this is a myth that Calhoun and others, including myself, want to demystify, and this presentation can help with that. Another article from 2005, The Fetus as Our Patient. So that's another nice article to talk about how to address patients and colleagues when it comes to the fetus as well. How do we address the care of the fetus? And it's really important at the outset to talk about the terms we use. So we don't want to use terms like lethal or fatal anomalies, but instead speak about life-limiting illness. So here's the first case. The case came up in my family practice, a couple with 7 children who discovered several anomalies. So severe spina bifida, hydrocephalus, clubfoot, and other anomalies. And so I journeyed with this couple through their pregnancy all the way to birth, and they had a planned C-section after the ventricles were drained of fluid because of the head size to manage the outlet of the C-section. Unfortunately, she had an intracranial hemorrhage as the likely cause of death. But thankfully, we had the whole family there, including the grandparents, and everybody was there along with the parish priest for a baptism before she passed away. And my role as a family physician navigator began with this case, and I'll tell you a bit more about my program a little bit later. And these pictures kind of show a family in love, and you can see if you scan that QR code in the center of the page there, you'll see a beautiful video that was made by her sister to show how much of an impact this little baby had on her family, but also the community around her. So instead of calling this case spina bifida, we can call it a family in love. A few lessons learned: the need for accompaniment with a family doctor when there's a difficult diagnosis, the value of when planned C-sections come in handy, the concerns about ventriculocentesis, whether that precipitated the intracranial hemorrhage with breaking of bridging veins, it's possible, the importance of having families present, and the importance of the institution making sure that mothers and babies are not separated for too long after birth after a C-section recovery. Case number 2, hydrocephalus and Duane syndrome. So this is another case where hydrocephalus was involved with multiple anomalies. And I was referred to by the MFM doc who took care of the first case. And they knew me and they knew that I had experience with accompanying these patients. She also had a planned C-section, but they did not do the drain of the ventricles, and this baby is alive and well today. She had a straightforward resuscitation, but making sure that attention to that very tender head was done while they were doing the intubation. And so instead of calling this a case of hydrocephalus, we can talk about the joy of life that this baby has brought to their family. And we have a little video here. I'll try to play it.
Back. Good girl. Oh, good girl.
You're walking now. And a beautiful thing about, as you can see her walking, eating the mouth.
Yeah.
Look at how gentle the mom is with her head when she falls.
Good, you got me. Can you go back to the couch?
She just wants to fall back. And her mom knows exactly what to do.
Go back to the couch. Back.
Here's another picture.
Hey, coming to you. Back to Dad.
Duck.
Back to Dad. Dad, cheese. You're not gonna pass it to me.
So I just wanted to show you the.
Come on. Whoa, there it is. Good job. Hey.
So a few lessons learned: the importance of team planning, which really helped with all of this; the importance of having a supportive obstetrician who can help the process, and presenting a message of hope to families. Case number 3, sorry, that's a mistake here. Giant omphalocele. Initially diagnosed as hydrops, the parents were told that the baby would not survive more than a few weeks in utero, and so she should have a C-section very early or an induction of labor, and the parents did not want to go that route. And it was complicated by a maternal issue, which is placenta precreta. She was told that invasion of the bladder would be life-threatening. So they were also my patients. We got them in touch with an MFM who was willing to try a different approach, and we were able to get this baby well into the 33rd to 34th week of pregnancy with a better prognosis for the baby. The baby's surgery is next week to reduce the omphalocele. They let the baby kind of have the skin grow around the omphalocele so that it's not so thin and membranous, and she is ready to go at 2 years old for her omphalocele surgery. So just again, look at these beautiful smiles, these beautiful pictures of a baby who's alive because of an approach that we took with perinatal palliative care. Remembering problems with ultrasound and misdiagnosis, and never just hanging our hat on one potentially negative diagnosis, needing to balance maternal and fetal complications, and even that there are support groups I wasn't even aware of. There's this one blog that's really good called Baby and the Onf. So we've had other cases too: aortic coarctation, trisomy 18, anencephaly, heterotaxy with the organs of the chest and abdomen being flipped, and conjoined twins. And we've had to manage all of these in different ways. So I have a family physician navigator program, so the MFM docs know to refer to me. And there was a case report about that first case I talked to you about, where my role as a family physician helped through the prenatal and birth process. This is a book I give to all of my patients. It's by Amy Kublek, who's had a complicated pregnancy herself, and now, believe it or not, is the one to support all of the doctors who want to do work like this. So I buy this book for all my patients and give them this reading material to get them ready for the challenges ahead. And Dr. Calhoun also has an excellent presentation that's linked there as well. Here are some research papers, which I'll let you pause and copy down if you need. And a network, which I encourage anybody who's interested to get involved with. You can sign up to the listserv and get emails, or you can contact me as well. So thank you to everybody who was able to tune into this presentation, and I hope it was helpful, and I wish you all the very best in your upcoming careers.